Hello everyone, welcome to your lecture on the GI system and with the focus on bowel elimination. These are the objectives that we will be covering in this lecture. The next few slides are just a review of the anatomy of the GI system. Please read over this. There are some important terms that I've highlighted in red. Here is some information on digestion, the parts of the body that are involved in digestion in the GI tract. And please read over this. This is just basic anatomy stuff. We have gallbladder and pancreas, the phases of gastric secretion. These are all very important for you to know in order to understand how digestion takes place and how it affects elimination. So let's talk about elimination. What is the process of bowel elimination? First of all, the term defecation obviously means process of elimination or waste. Feces is basically your bowel movement, right? Your poop. It's semi-solid mass of fiber, undigested food, and inorganic material. So fecal material basically stretches your rectum and it causes it to distend. The stretched receptors are stimulated, the internal sphincter relaxes. At the same time, the sensory impulses are transmitted to the central nervous system and they produce a conscious urge to defecate. Normally, stool should be soft formed, semi-solid, approximately 75% water and 25% solid. Normal bowel function means that the patient is able to pass stools without excessive urgency. That means when they're constipated and they're pushing that need to, or the need to rush to the toilet, for example, you're running, to the toilet with minimal effort and no straining, without any blood loss, without the use of laxatives. You can regard bowel function as normal if all of these, criteria are met. If the signal to defecate is ignored, and sometimes people do that, right? For example, they're not close to a bathroom, restroom, or they're busy and they, ignore the urge to defecate, the reflexive contractions ease for a few more minutes until mass peristalsis occurs again. So this is what, different pictures of different types of poop. Fun, right? So like we said, this is the definition of normal bowel function. And these are the different types of, bowel movements and kind of one word description of what could be causing it. So your normal, smooth, soft, semi-solid is your normal. And when you're charting in the hospital, depending on which facility you work for, they will have a similar chart like this. This is one of the common charts, and in order for you to be able to describe it. What are characteristics of, feces? Obviously the color, right? Abnormal is white or clay, black tarry, it could mean blood in the stool, red, pale, and oily. The odor is normally malodorous, of course, and certain foods, do affect it. If there's, like a noxious change in the smell, then it could mean blood in the feces or even infection. Consistency should be soft and formed, and if there's liquid and very hard, then that's abnormal. And liquid is basically considered diarrhea, and that occurs due to reduced absorption. Or it can be very hard, and that could be caused by constipation. Frequency, for infants, it's a lot more, of course, 4 to 6 times a day, basically, if they're breastfed, or 1 to 3 times a day if they're bottle fed. And for adults, it's twice a day or 3 times a week. And it's extremely important for us to know the baseline of our patients. Shape resembles, the diameter of the rectum. Constituents, you have what does it constitute of? Undigested food, dead bacteria, fat, bile pigments, cell lining, intestinal mucosa, and water, right? Things that you should not see in the feces are blood, pus, foreign bodies, mucus, worms, Oily stool is also abnormal, and any mucus in the stool is also abnormal. And they can indicate bleeding, infection, swallowed objects, or just malabsorption syndrome, pancreatic disease, and, a list of things. What is peristalsis? Is the movement of, the food after we eat it through your intestine. This is a great video. Please take some time to watch this video.
The autonomic nervous system.
Okay, so factors affecting bowel elimination, right? We said in the previous few slides, we talked about what normal bowel elimination should be. No straining, no urgency, and the characteristics that are normal. We need to, understand what normal is first. So now let's talk about factors that affect, the norm, like affect bowel elimination. Developmental stage, right? Changes throughout lifespan. For example, we said kids, babies poop a lot more than adults, right? Then you have personal and socio-cultural factors like privacy. I mean, obviously, if you need to, defecate and you're in the mall, you're not going to just start defecating where you're standing, right? Suppose you don't have access to a bathroom. So, things like that can affect, bowel elimination. Habitually, people who ignore the need for bowel movements can eventually develop bowel dysfunction. Nutrition, hydration, activity, regular eating schedules, regular defecation patterns are extremely important. Foods, high fiber foods promote peristalsis and defecation. Fresh fruits, vegetables, whole grains are all great for, digestion. Then fluids, we need to have a minimum of 6 to 8 ounce glasses of water a day. That's about 1,500 to 2,000 milliliters a day of fluid. Then activity, physical activity actually promotes peristalsis, the movement of food digestion in your body, right? A sedentary lifestyle can cause weaker abdominal muscles, and limited mobility will lead to constipation. That's why it's extremely important when patients are in the hospital and they have that limited mobility, if they're bedridden, to, somehow help them, do some activity, movements and stuff like that, turning them, things like that, because that helps, right? Stress causes diarrhea, constipation, IBS, bloating, pain, altered bowel function. As you can see, stress affects everything, right? Medications, medications like antacids, NSAIDs, antibiotics, iron, analgesics, anti-motility drugs, laxatives, all of these can affect bowel function. Surgery and procedures can affect bowel function as well because of the anesthesia that patients are given and the stress of surgery, and these can sometimes lead to paralytic ileus. Pregnancy affects intestinal motility as well. It slows down, everything slows down. And then pathological conditions such as neurological disorders, like people who have TBI and CNS disorders, can develop altered bowel function. Then you have patients with, who have, impaired cognitive ability. They lose the sense to urge to defecate, and then they forget. And so you see that a lot in patients who have dementia. They tend to forget that they need to, go and have a bowel movement. So it's important to help them create a schedule so they can have regular, bowel movements. Pain and immobility also can make your peristalsis sluggish, slows it down, right? Any pathological conditions of the GI tract can slow that down as well, or make it too fast, right? So physical activity promotes peristalsis, immobilization slows it, and you'll notice this, like patients who are bedridden in the hospital, when you move them around, all of a sudden they have bowel movement, and it happens a lot of times. You turn them to the side, and it, promotes the peristalsis, and they have a bowel movement. Positioning, squatting promotes defecation. That's the normal position for defecation. Lying supine makes it difficult for muscles to contract and defecate. I mean, when we need to use the bathroom, we sit on the toilet, right? And our knees are bent and almost like a squatting position, close enough. I mean, we don't lay down in the bed and defecate, right? So of course, that's difficult for patients to do when they're in the bed. What are some common bowel alterations? We have diarrhea, we have constipation, which can lead to fecal impaction, then you have incontinence, and then we have bowel diversions, similar to urinary diversions. So let's talk about diarrhea. That's basically loose, unformed, watery stools. Chronic above a month. Acute is a response to an infection, unusual foods, and causes can be viral, bacterial, antibiotic therapy, inflammatory bowel disease such as irritable bowel syndrome. Complications, of course, when you're having a lot of diarrhea, you're going to have fluid and electrolyte imbalances, right? Especially potassium. You'll lose that. And, you'll notice that they suffer from hypokalemia because they're losing a lot of potassium. Impaired skin integrity, because if they have diarrhea and they're constantly moist, and we need to make sure we provide immaculate, perineal cleaning, because that can lead to skin breakdown. Altered GI flora, dehydration. All right, so the cues that we're going to recognize is the bowel pattern. What is their normal bowel pattern? Their dietary pattern. Any fever, nausea, vomiting, or abdominal pain that can indicate infection. You want to check for the skin and mucous membranes. Are they, dehydrated? Are they moist? Abdominal, do they have any abdominal cramping? If they do have a bowel movement, you want to look at the characteristics of the stool, right? Does it have like mucus in it? Does it have blood in it? We need to recognize those cues. And here are some hypotheses that we can, and just solutions we can generate for our patients. For example, diarrhea, GI motility, alteration, risk for deficient fluid volume if they have diarrhea, right? Risk for impaired skin integrity. Interventions that we need to take are teach about hand hygiene, identify the cause, monitor stools, fluid balance, electrolyte levels, administer any medications to slow peristalsis if it's ordered, right? Cleared liquid diet or electrolyte replacement and fluids. These are all ordered by the doctor as well, but we can encourage fluids. We need to make sure that we can encourage PO fluids in our patients. Reduce fiber, limit caffeine, maybe give them the brat diet, right? Bananas, white rice, applesauce, toast. Provide prompt hygiene, provide toileting assistance. The diagnostic procedures that we can utilize are fecal occult, and we're going to practice in skills labs. Stool cultures, colonoscopy, sigmoidoscopy are some, diagnostic procedures that you'll hear of. So constipation is obviously the opposite of diarrhea. Constipation is just decrease in frequency bowel movements, right? So if the patient normally, has a bowel movement 3 times a week, if it's less than that, then, or incomplete passage of stool, or it's very hard and it's less than 3 times a week, then it will be considered constipation. But it's important, like I said, we have to make sure that we know the patient's baseline. Short term can be temporary, right? Symptoms resolve in a short period. Chronic constipation lasts for more than 3 months, and it can persist for years, and it happens in older adults because of the frequent laxative use and stuff like that. Causes slow motility, causes fecal masses to become exposed to the intestinal walls. The water content from the mold is, mass is absorbed, and so there's no water left in there to soften and lubricate the stool, right? So then you have this strong, hard, fecal mass. And this is caused by irregular bowel habits, ignoring the urge to defecate, chronic illness, low fiber diet, low fluid intake, stress, physical inactivity, changes in life routine, for example, pregnancy, aging, travel, neurological conditions, that block nerve impulses to the colon, chronic bowel dysfunction. If a patient is constipated or they have fecal impactions, they can develop a lot of complications, including like hemorrhoids, rectal fissures, and anal bleeding. Paralytic ileus, a huge one. Fecal impaction, right? It can basically get impacted and just be stuck there, and we have to actually digitally with our fingers remove it. And when you do that, you have to be careful because it can cause bradycardia and hypertension, syncope. That's the Valsalva maneuver, right? And you have to be extremely careful. There are a lot of nerve endings by the rectal area. This fecal impaction is basically hard, dry fecal mass in the rectum, making it impossible to pass the stool from the body in a normal manner. This blockage sets up a cycle of further hardening with new ways backing up and higher in the colon. And so now you have this huge backup, right? And that can cause a lot of problems. Okay, so this is the care plan for constipation. The cues that we need to recognize and we need to monitor for subjective. This is what the patient might tell you. They have bloating, they have cramping, they strain when they defecate, they have dry, hard feces and it's difficult to pass. They've had irregular bowel movements, they're pooping less than 3 times, a week, which is, the client's, we need to find out the client's normal pattern, diet, how they eat, how much fluid they take in, how is their physical activity level. Objective, we need to check for bowel distensions, we need to listen to bowel sounds, we need to check for blood in the stool. If you notice any decreased frequency, decreased volume of stools, hard stools, hyper or hyperactive bowel sounds, all of these are assessments that we need to do. And here are some hypotheses: constipation, risk for constipation, decreased GI motility, lack of knowledge of dietary regimen, right? Patients might have that, and then we can teach them. How do we generate solutions? These are the goals, some sample goals that we can set for our patients. And actions that we can take, we want to make sure we provide them with uninterrupted time to defecate. Be patient, let them take their time, don't rush them, provide privacy. Sometimes, people put like the bedside commode right next to the bed and the curtain is open. And it's embarrassing for people to sit down knowing people are walking by and watching them sitting on the bedside commode, right? So we want to provide privacy. So they don't have the stress and they can actually take their time to have a bowel movement. We want to always remind them not to ignore the urge. Assist them with the toileting. Encourage fluids, 8 to 10 glasses a day. High fiber foods. Encourage physical activity. If we need to give them stool softeners, if the doctor orders it, or enemas, then we need to do that. If the doctor orders a if there's a fecal impaction, the doctor might actually order for us to manually remove the stool. Right? Monitor for any anal fissures, hemorrhoids, bleeding, and all those things. Pattern of bowel movement changes. We need to always also help them with bowel training, right? Say, for example, okay, let's try every 4 hours. We're going to put you on the bedside commode or the toilet, and, a certain timing, the positioning, perineal hygiene. All those are important. And how do we know that our interventions worked? The patient has a regular defecation schedule. They list proper fluid and food intake needed. They implement a regular exercise program because they need to move, right? They report daily passage of stool, or at least 3 times a week. Form brown, soft, semi-solid stool, like the normal texture of stool should be. And they do not report any straining or discomfort. So enemas are used when patients are extremely constipated and they're just not having a bowel movement, right? So enemas basically help remove the feces from the colon. Basically you'll administer it, and then we'll go over this in skills lab as well. And they retain for a period of time, and then they return the flow. So it helps to expel the flatus. So basically you put it in, they hold it in, and then, they expel the flatus, right? This helps to relieve bowel abdominal distension. And usually it's used most of the time in hospice patients because, they're bedridden and a lot of times, and it slows down their peristalsis. And here are the different types of commonly used enemas, and we will go over some of these in skills lab. Incontinence, is the inability to control the discharge of feces and flatulence because of the moisture and activity of enzymes in the stool. Clients with persistent bowel incontinence, they need special nursing care to prevent impaired skin integrity. What are the causes? Conditions that affect the innervation of the rectum, right? Uncontrolled diarrhea. Impaction resulting in leakage of stool. Sometimes the stool leaks from the sides of that impaction. Cognitive or emotional changes that, affect your gut, like dementia, low level of consciousness, functional limitations. For example, a client recognizes the need to defecate but can't get to the toilet independently, right? So we want to help them get to the toilet. Recognizing cues. What do we recognize? Bowel patterns, factor related to fecal incontinence, and see if they have any medications or what diet or activity levels that are maybe causing the incontinence. Check for, make sure they check their perineal skin condition, any medical problems, psychosocial behaviors, other risk factors, for example, smoking and being underweight. So these are some hypotheses and goals that we can set for our patients. And what are some actions that we want to take when our patients have incontinence? Monitor for bowel movement and patterns, skin breakdown, redness, or irritation. Treat, designate uninterrupted time for defecation. Give them the time, provide assistance, provide privacy, help them with bowel training, right? Provide skin care, change soil linens as soon as possible, provide prompt hygiene, use skin protection products like, moisture barrier creams. They're zinc based and extremely good for the skin. Consider putting absorbent pads and shields to keep from, their incontinence, their stool from, soiling the clothing and linens, right? Make sure that proper diet, fluid intake, skincare. And these are ways we can evaluate our patient if whether our interventions have worked. Bowel training. Bowel training is extremely important. We have to help our patients develop that schedule, right? We want to assess normal elimination pattern. Choose a time based on the patient's pattern, right? Don't say, no, you're not going to do it this way. We'll do it this way. Try to work around their preference. Remember, patient-centered care. Offer like a hot drink, like hot tea or fruit juice, for example, prune juice, or whatever fluids normally stimulate peristalsis for the patient. Ask them, what do you usually take that helps, right? And give that to them before the defecation time so it can help them defecate. Help the patient to the toilet at a designated time. Provide for privacy. Instruct the patient to lean forward at the hips while sitting on the toilet and apply manual pressure with their hands over the abdomen and bear down. But help them, teach them to not strain, especially our patients who have cardiac conditions. We want to always, extremely important to always remind them to not bear down, because that can call the Valsalva maneuver, cause that, and it can cause them to get bradycardia and affect their health seriously. And a hurried environment and non-judgmental care. Come on, like telling our patients, come on, I have 5 other patients, so you need to hurry up. No, we don't want to do that. We want to give them their time. Maintain normal exercise with the patient's physical ability, obviously based on what the patient's ability is, right? We don't want to tell them, okay, let's go for a jog, when maybe they just had surgery. So work with the patient. Review the medication regimen. See if the medications they're taking are affecting the bowel patterns. And a lot of times they do. Common labs that we see are like fecal specimens, right? The lab provides special containers. Some require chemical preservatives. Some have to be, refrigerated, placed on ice, or room temperature. So it's important to collect at least 3 centimeters, about a little over an inch mass of formed stool, or 15 to 30 milliliters of liquid stool, right? It's a very small amount, right? And the lab sometimes will tell you how much they need. They'll have the containers marked with the line, and they want about that much of the, specimen. They should be obtained accurately, labeled improperly in appropriate containers that the lab wants them to be in. And then transported to the lab on time. Because you don't want to go through the whole process of collecting the specimen, putting it in the container, you send it to the lab, and the lab says that's the wrong container, so you have to do this all over again, right? So it's extremely important to just do it right the first time. Medical asepsis, make sure it's not a sterile procedure, right? There's nothing sterile about it. We just need to make sure we maintain medical asepsis. Take your standard precautions, wear your gloves, hand hygiene, washing your hands, all of that. Avoid mixing feces with urine. Sometimes when we need to take a stool sample, we need to try to avoid mixing it with the urine. We don't want the urine in the stool as much as we possibly can, right? Another type of test is what we call the guaiac fecal occult blood test, right? Or fecal immunochemical test, FIT test. And this is done annually. But the guaiac test usually measures for any microscopic amounts of blood in the feces. And it's used to test for colon cancer. And we're gonna go over this in skills lab as well. It needs to be repeated at least 3 times on 3 separate bowel movements. Positive results will follow up with a flexible like sigmoidoscopy or a colonoscopy. And it's important for us as nurses to know the procedure for how to collect the fecal occult blood tests. And normally the doctor, we need to get a doctor's order first, and then we do it. Hemoglobin and hematocrit is also checked, right, to diagnose GI bleed. So if the person's hemoglobin and hematocrit are low, it could indicate, GI bleed. Liver function tests, serum amylase and serum lipase. These all help to diagnose hepatobiliary disease or pancreatitis. So these are just a few common labs that you'll see. Common diagnostic tests. So sometimes you have direct visualization tests and indirect visualization tests. Direct is endoscopy, right? Your gastroscopy, colonoscopy, basically a lighted fiber optic tube is used to gain direct visualization. So they'll put this little tiny camera inside through your colon and to visualize the GI tract, right? To see if there are any lesions or polyps or anything like that. And sometimes these can be removed for a biopsy to see if are there any cancer related ones, if it's cancer related. And is done under sedation, usually in outpatient centers. So basically, to prepare, patients receive instructions about the preparation needed for the test at the time they're scheduled. They'll give them the list of all the things that they need to do before they get there. Usually they need to be on a clear liquid diet, or day before the test, bowel preparation, for example, they'll give them liquids and stuff like that, or medications to help cleanse out their bowel, right? So the doctors can do the colonoscopy. Indirect visualization would be where you don't have a direct visualization of the GI tract. So you have the anorectal manometer, right? Or you have the KUB, we call kidney, ureter, bladder, KUB, a simple x-ray of the abdomen, and it doesn't require any preparation. They don't have to be, NPO or anything like that, unless the doctor orders it that way, all right? And then you have the barium swallow test or enema. And then you have computed the CT scan. It's usually done every 5 years. It helps to examine the body from different angles, right? And then colonic transit study, we call it. And then you have your MRI, which is a non-invasive examination as well. And if you notice over here, for barium swallow test, they need to be on a clear liquid diet, laxatives the day before the procedure, and any enemas. For the CT, oral contrast solution for the patient to drink before the test, or IV contrast solution is injected during the test. And what's important for us to know, do they have any allergies, right? We want to make sure they know all the entire procedure, and patients should not have food or fluids 4 to 6 hours before the exam, before the CT. Colonic transit study, patient maintains a normal diet intake for 5 days, and then refrains from medication that affect bowel function on the 5th day the x-ray is taken. MRI, they have to be NPO 4 to 6 hours prior. Patient lies very still. We have to make sure they have no metallic objects on them, any watches, jewelry, anything like that. Patients with pacemaker or metal implants cannot have an MRI. These are bowel diversions, similar to urinary diversions. You can have an ileostomy, stoma formed from the ileum, small intestine. So obviously, as the stool is going down your GI tract, and depending on where the, ostomy is placed, the characteristic of the stool will depend on that. For example, if it's in the ileostomy, it's going to be liquid stool, because your stool forms as it's going through your GI tract, right? So the closest you are to the rectum, the more formed the stool will be. And one more thing over here, I want to make sure this is, a normal stoma. It should be red pink, formed like that. It's extremely important to always assess this properly. Make sure that, if there are any changes, any problems, we need to make sure that, that we report it to the provider immediately. So these are stoma appliances, and we're going to practice this in stool lab, and this is how we place the stoma. And please go over the skills list I gave you guys in class to go over the procedures to do this, so we can practice this in lab. And these are some stoma complications. This is dehiscence, where you see the opening over here by the stoma, it's opened up. There's a separation from the stoma to the surrounding tissue. Stoma retraction is when the stoma basically kind of goes inwards. If you notice, it's like gone, it's inside. You have stomal prolapse, where the stoma, just the whole part of your intestinal tract is outside your stoma area. Stoma necrosis is when there's dead tissue, there's no oxygenation getting there. It's extremely important that the provider be notified right away. Then you have hernia of the stoma. Underneath, if you notice, there's this bulge. And then stomal stenosis, where the stoma just closes up. So these are important things that we need to do to maintain stomach care, to provide stomach care to our patients. We need to assess the three S's, extremely important: skin color, lesions, stoma, the skin, stoma, and stool. These are the three S's. So skin, we need to assess for color, lesions, if it's necrotic, if it's, we need to check for all of that. Then we need to check the stoma, what the color is. Is it moist, pale? Is it blue, black, right? Is there a prolapse? We need to look for all of that. Stool consistency. If it's an ileostomy, then it's going to be semi-liquid stool. If it's, you shouldn't see hard formed stool over there. If it's a colostomy, then you will see more formed stool in the stoma, right? Then you want to assess for complications like the dehiscence, the prolapse, excessive bleeding, ischemia. If it's blue and purple, we need to notify the provider right away. These are some hypotheses and goals that we can set for our patients with stomas, and these are the interventions. We want to assess 3S's. We want to provide stomach care per protocol, keep the patient free of odors. Sometimes they have these charcoal filters inside the stoma bags to help with the odor. We want to empty the appliance before it's half full. You don't want to wait till it's like completely full, and then you'll have a bigger problem, a lot more work, because it's going to explode and then there's going to be poop everywhere. So before it's half full, just empty it out and change the bag, or empty it out and record the output. It's keeping surrounding skin clean and dry, extremely important, because you don't want moisture associated skin damage, and because that can cause a lot of problems around the stoma. Prevent complications, notify the provider if they occur, measure eyes and nose, involve the patient and caregiver in the stomach care, because we want to teach them how to take care of it, right? Because especially if they have to go home with it, we need to provide proper training. We want to also provide coping strategies and psychological, physical support for patients, because nobody likes a stoma on them. Nobody wants that pouch there. It's not easy for patients to adjust to it, so we need to provide that psychosocial support. And if we need to ask the doctor for a psych consult, we can even ask for that. Teach appropriate diet. Teach them to avoid foods that cause a lot of gas or odor, right? And then you want to maybe encourage them to eat bland, low residue foods. Avoid foods that can cause gas. Chew food properly. They want to make sure that they chew properly. Then prevent excessive weight gain and stay hydrated, because when patients gain a lot of weight, it can cause a lot of stoma complications. Well, that is it for your bowel elimination lecture, and I will see you in class.